it took me 15 years, would you say, to forgive you for your privilege. I remember insulting publicly, but I definitely have now. And so I'm going to speak from that slightly unreasonable point of view. I'll just say to Walter, I mean, we've experienced somebody who's very distressed and using language and behaviour in a way that draws attention very strongly. Nobody has any choice. And, you know, I want to use a little bit of that myself, if I can. And I put it to Walter, what is the role of unreasonableness in all of this? And Bernard Shaw's something quote, and it takes unreasonable people to change the world. And I'm sure all of us will be remember what happened this morning and change our behaviour slightly as a result. You know, it's very unfortunate if you're the target of that, but it's still, it is, you know, a powerful message. So I don't know if Di remembers this place. It's Uchu in Central Australia. And I'm not going to talk specifically about Aboriginal people, but I'm going to talk about what I see as really, do I push that button? Is that how this works? Try again. Push it twice. Do I do that each time? No, I just did it once. Okay. So I'm a director of a large Aboriginal medical service. Anyway, she mentioned, and I think you will feel from her introduction how important Aboriginal medical services or ARCHES, Aboriginal Community Controlled Health Services are. Congress, where I work, is 50 years old this year. She mentioned Redfern in 1971, the second in the country. Charlie Perkins, all the radicals in Central Australia, set up Congress based on Gandhi's Congress. And it's been there ever since. It's now 500 employees, it's been over half our Aboriginal. Extraordinary organisation. But we've got problems. You've read, no doubt, in Alice Springs of something that probably makes you not all get up and look in the paper and say, is there a job going for me in Alice at the moment? And that's impacting us in a really big way. We've got major health problems. Uchu, the community I just showed you in the beginning, has 47% of adults, that's 18 and above, with diabetes. You know, that's the worst in the world that we know. And just an extraordinary flow on from that with kidneys disease. As a GP before going to Congress, I had 1 or 2 patients in my career on dialysis. Now I've got 500 patients on dialysis. So really big health problem. People on both, everyone is exhausted, and given all the problems we've had, but we were already exhausted. Now we're like pretty desperately exhausted. Just on Saturday morning, I saw 34 people, mine with 2 nurses, to try and just meet immediate needs of people. And this is in Australia, you know, this is the country everybody thinks is giving everyone a fair go. And anyway, so we've got clinics closed now, so the government, because of lack of staff. So I'm going to talk to you about that little area of Australia, which is the area that we as a health service cover. And we've got, you see Alice Springs up here, you can see the rock, and the Western Australian border, that's the South Australian border there. And we see quite a lot of people from South Australia. And these are the clinics. We're just taking on 2 at the western side. But I'm going to talk a little bit, because ANU are involved with us in Manta. You might have driven up the Stewart Highway. So there's no other healthcare other than ours for 7,000 people on any given night in this area. Now, the good news for us is 5,000 of them are white fellas visiting Uluru. So that helps. That gets our sort of profile up. We're just starting that in March. We used to only look after Aboriginal people, but now, because of Voyage's 400 staff and 15 Aboriginal now at Uluru, so it's becoming a kind of a feature, I guess, of the whole tourist experiences that you look after by Aboriginal people. And now, if you go to Dilara and get sick, you're going to be looked after by an Aboriginal medical service, which is kind of exciting. And things have changed. So traditionally, our healthcare in this part of the world, this is the nun. not looking very nun-like, but, and that's a flying doctor. And that is really, if you're going back through history, that is Australia. Now, these planes used to land at cattle stations. That's cool. Looking after white fellas who got sick, and the nuns looked after everyone else. And unfortunately, if you're a nurse now and you work in the bush, you actually take on the job of the nun. And you work 1 in 3, you get up any hour of the night. It's really a tough job. And it's, for some people it's sustainable, but I would say most of those are over 50, and the job itself is really very difficult to do. And if I go out bush, I usually take it on call just to give people a rest. There's one kind of hybrid I found when I was looking for pictures. I don't know that. Does anyone know this one? But the flying nun sounds like a good idea, doesn't it? It's kind of bringing it all together. But it's probably not the answer to our healthcare in Central Australia. So, what's going on? So, clinic's closed. In Manpur, I showed you, it's 200 kilometres from the nearest clinic. It's been closed for a while before we've taken it on. It's between 40 and 80 people living there, about 200 miles away, 200 k's away. If they get a sick child, a call, a nurse has to drive 200 kilometres in the middle of the night. In fact, 2 nurses go, because after Gail was murdered in out of the world, nurse, you're not allowed to go on your own. 200 kilometres, check everything's all right, 200 kilometres back. You're obviously not much good for anything else for that day. So it takes 2 members of staff out of our system for 1 person who's in trouble in that part of the world. So can we do anything about this? So just what sort of solution? So I'm going to talk about this area. At the moment, we can do remote triage, and we kind of do that a little bit, but it's hard to sustain. And by that, I mean talking to a patient who's 200 kilometres away. Just use the example, a woman sort of desperately talking at 3 o'clock in the morning about her son with a sore neck. You know, that's a worry. Then so get up and go to the clinic, and the car pulls up, and the kid jumps out of the car and sort of runs through. Okay, I didn't really need to get out of bed. Yeah, and neck meant throat actually. But because of English, whatever, didn't get that message across at all. So, you know, but the important message that I'm trying to get there is how important vision is. So, just this idea of digital first. Now, I'm going to raise it here, but I think this applies everywhere. But it is most relevant to us, and I hope you'll see why. So I'm going to tell you about this because I was telling God I'm going to bring this up. What is that? Now, we just, Russell Bruin, the Dean of Medicine, was at Manpur when we turned on the Starlink, and we went from 4K link, they had the best link of any of our openings, up to 140K megabits. Usual satellites guarantee us 600K, that's like an old modem 20 years ago. And we have awful trouble where you type and you see the letters. Remember those days when you type and then okay. It's going on a little bit here this morning, and actually the reception in this place is unbelievably bad. It's not really mobile, something like remote Australia. But now we are. I just want to tell you, I just want to announce it here. We are way ahead of you, all of you. But seriously, every one of our clinics is online now. We've done it for a few weeks, and we've got better bandwidth than any of you have anywhere. Why? Because these things are flying over the top of us, and they're not very busy. When they're over the top of us, there's 42,000 of them up there. Somebody said, "What's that thing saying?" I don't care. It's not my problem. It's wonderful. It is extraordinary. So we've got these things flying over. It took a while. We had a few gaps until maybe a month ago, where the Zoom would just breathe and then take off again. And now it's just this. So what kind of disruption? What kind of, you talked about flipping it. This has flipped the world from remote Australia. What can we do? What can we do now? Now, we've been dreaming about it for a while, but we can do it now. And I think it's the most important communication area just to consider. The implications we don't really know, but we're talking about in a mammoth. I've got to get a door put into a mammoth to make this all work. Just got to tell you, that's really difficult. There's a window. You know, if you've got a nice big angle grinder, I can just go down and decide to put a door in there, but oh my God, it's owned by the health department. Yes, and I've got Natasha files on it now, so I think I'm going to get there. This is unreasonable bit I was talking about. So what sort of things could you have? You've got to open the door from a distance. This is no star. We can get somebody with really good equipment. We can see them, and we can do a single lead ECG very easily. This is all with Indian technology, a few $100s. The alternative is to put a nurse and a 12 or 13,000 litre kit to get the same thing. That isn't sustainable, especially if we're going to do it and replace it and gets trashed every now and again. When we say, like what happened this morning, no, we can't do that for you. That leads to immediate responses, sometimes a bit surprising. And that's the bit of Indian here, the ECG leads, and it costs $180. And it's a crowdsourced bit of work, and it's all open source. But very interesting. I like that picture of the rock from the clinic at Mutijulu, and I looked outside and there's all Aboriginal people standing going, oh wow, I thought, oh, must be something going on out there. It was kind of religious experience here, and this big halo at the top. So what would it look like? We've got a couple of PTZ cameras. You're looking at, I couldn't find a kind of regular person. It's really hard. Even look at the front of the thing you hand out. You've got to put beautiful people everywhere now. You can't just have ordinary fellas or people off the street. So we've got a close-up camera, so you can look at a sore or a cut or anything like that. Pulse oximetry, so we know if their breathing's okay, the pulse rate. Thermometer, it's built in, and a single lead ECG. So we can really see quite a lot about people and talk to them and see them with this. The advantage of these cameras is you can see them walk in, sit down, all the body language. I mean, not just the face, but you've got the face as well to look at. Thank you. I think that's nearly my last slide. Probably the most radical idea is these remote pop-open lockers, so we can dispense as well. And in there, so the little cameras in there, that is fairly high expensive camera that we've got with a lead on it. But we can secure things and then actually deliver some care and probably some oxygen and things. All right, so that's all I wanted to say. I hope that's okay. We do need help. ANU is helping. We're really pleased about that. But I think there are communication issues here that are new and interesting. And I hope you will join in and think about that. Thank you.